The diseases of the posterior pituitary are much easier than anterior pituitary. We've only got two hormones to consider, and oxytocin doesn't matter. So we're going to talk about what happens when you have too much ADH and when you have too little. Let's start off first with the syndrome of inappropriate ADH. We're going to use this to discuss the physiology and then go into a little bit about the syndrome of inappropriate ADH. This is the brain, and you've got the anterior and posterior pituitary, and from the posterior pituitary, ADH is secreted. And what ADH does at the level of the nephron is it tells the kidney to reabsorb water. That's what it's supposed to do. But if you've got either a brain lesion that's secreting ADH or a lung lesion, and these are the two places where extra ADH comes from, secreting ADH. Even if there's not a good reason to do it, the body is going to reabsorb more water. Now, what's going to happen, urine will still be made, but since all of the water is being reabsorbed inappropriately, the urine osmoles are going to become very concentrated. So the urine osmolarity will increase. Now the body knows it has too much water, and it's going to try to get rid of water. In the body, water follows salt. So the kidney is going to turn off aldosterone. It's going to turn off reabsorption of sodium. And so what you'll see in the urine is an increased urine sodium. When you have both the urine osmoles and the urine sodium increased, that is a good indication you've got ADH being secreted when it shouldn't be. So the pathology of SIADH is either going to be a brain lesion or a lung lesion. And the lung lesion you should associate with SIADH as small cell lung cancer. But I want you to know that any granuloma, any pneumonia, any lung lesion or any brain lesion can do it, but often it's going to be a malignancy. And it's going to leave you with excess ADH. Now the patient presentation, having reabsorbed all this extra water, is going to present with the serum osmoles that are low. And so the patient is going to present with hyponatremia. We learned this in the renal lectures, that sodium is really a measure of tonicity. So they'll be hypotonic and usually asymptomatic to the SIADH, except to the extent that they'll have hyponatremia, which may induce some symptoms. And so the diagnostic step, we've already talked about this, is to get a urine sodium, urine osmoles, and serum osmoles. And the serum osmoles will confirm what you're suspicious of with the hyponatremia. And the urine sodium will be elevated and the urine osmoles will be elevated. When they are in the same direction, something's wrong, then guess SIADH. The treatment is going to be water restriction. Any fluid you give them of any kind, including that which contains sodium, the water will be reabsorbed, the salt will be wasted away. So even if you bring their sodium up temporarily with fluid, over time, they're just going to hold on to the water and pee out the salt, and so they'll get worse. What you really want to do is reverse the underlying disease. Treat the pneumonia, treat the TB, resect the tumor. But if water restriction doesn't work, then what you're going to need to do is help get that excess water back into the urine. So you can induce diabetes insipidus by giving dimethylcycline. SIADH, where it comes from, recognize the urine sodium osmoles profile, and then water restriction to dimethylcycline if that fails. So I just mentioned diabetes insipidus. What is diabetes insipidus? That's the other way. Diabetes insipidus has nothing to do with glucose. You pee a lot and it is insipid because your glucose isn't elevated and you don't have glucose in your urine. The pathology here is going to be based on the same system, right? You had the brain, anterior, posterior pituitary, the posterior pituitary is supposed to secrete ADH, and the kidney is supposed to reabsorb water. Now it does that by activating ADH receptors. One of two things can happen that causes ADH to break. Diabetes insipidus is a problem of not enough ADH, or not enough ADH activity. If you break the production of ADH, it is called central diabetes insipidus. If you break the receptor, or the kidney, it is called nephrogenic diabetes insipidus. Regardless, remember, the kidney's still making urine. If you don't have enough ADH or your kidneys are broken, you won't be able to reabsorb the water, so excess water will end up in the urine. Excess water in the urine is going to dilute the urine, so the urine osms will be very low. All right, so pathology is going to either be central or nephrogenic. Nephrogenic is demeclocycline or lithium toxicity, and effectively you have too little ADH. The patient is going to present like diabetes, polydipsia, and polyuria. But they will have a normal blood glucose and no glucose in the urine. Because in diabetes mellitus, excess glucose in the urine that exceeds the Tmax of reabsorption draws the water out with it. In diabetes insipidus, there's no signal to draw the water back into the body. The diagnosis is going to be made with a water deprivation test. And what you're trying to do is figure out, has the person just had medullary washout because they've drank too much water, psychogenic polydipsia? Do they have central diabetes insipidus or nephrogenic diabetes insipidus? Here's how this test works. You bring someone into the hospital, and you're going to keep them for some period of time. And you know already that they've got very dilute urine. So you have them begin the test. And at some point you say, no more water for you. Water deprivation. And if it was just that they were drinking too much water, their body would be like, hey, I peed out all that excess water, now I need to hold on to some. And so their endogenous system will kick in, the ADH will work, and their urine osms will increase. This is psychogenic polydipsia. But if they have a problem with ADH, no matter how much you fluid restrict them, they are still not going to be able to reabsorb the water, so they're going to pee out dilute urine. And then your question is there ADH around, or is the ADH receptor broken? So you give them what you think they lack. You give them ADH. And if their urine osm's correct, they didn't have enough ADH around, that's central diabetes insipidus. And if you gave them the ADH and nothing happened, it means that the kidney can't respond to the ADH that's there. That's nephrogenic. The treatment here for psychogenic polydipsia is to stop doing that. Don't drink so much water. The treatment for central DI is to give them what they lack. That's vasopressin, DDAVP, intranasally. And nephrogenic, this is tough to understand why you would do this. I just want you to memorize it and don't worry about the mechanism. But in nephrogenic diabetes insipidus, what you want to do is gentle diuresis, using either hydrochlorothiazide or a combination with amelioride. It may not make sense to you, the fact that we're giving them a diuretic, but that's how you treat it when all else fails. And of course, if you're able to release whatever underlying disorder caused it, like lithium toxicity, wait to ride it out. Okay, so SIADH, too much ADH means too much water reabsorbed, urine gets concentrated, serums get diluted, water restrict, reverse the disease to demeclocycline. diabetes insipidus, not enough ADH, so the urine gets really dilute, figure out how you can concentrate it with a water deprivation test by water deprivation, then giving ADH, and based on the final result, treat accordingly. Being able to identify someone with diabetes insipidus by polyuria, polydipsia, normal glucose. That is posterior pituitary.